everybody. I'm Dr. Donna Reece, and I'm now joined by our international guest ambassador, Dr. Ajai Chari. He will summarize abstract 412, which is the Apollo trial.
Hi, it's a pleasure to be here. And the Apollo study basically is asking the question of what happens when you add Daratumumab subcutaneous formulation to Pom-Dex backbone in a randomized phase 3 fashion. We know that subcutaneous Daratumumab has shown comparable efficacy, improved safety, and of course, markedly improved convenience. And Pom-Dex, of course, is an important backbone. But in this study, the question is in patients who've had at least one line of prior therapy, what does the addition of the CD38 do on a Pom-Dex backbone?
What were the key highlights from this presentation in your mind?
Well, the primary endpoint of the study was progression-free survival. So that endpoint was probably the most important takeaway, and the PFS was 12.4 months in the experimental arm versus 6.9 in the control arm, which translates into a hazard ratio of 0.63 or 37% reduction in the risk of progression, which is significant and encouraging. So that was the primary endpoint. We did see that depth of response was also improved in terms of CR rates and MRD negativity by 6-fold and 4-fold respectively. And I think those were important to see. In the important question of Len refractory patients, what was the outcome there? The hazard ratio was very good, 0.36, but the numbers are a little disappointing. The PFS for the Len refractory with the addition of Dara was 9.9 months, and the control arm was 6.5 months. In terms of safety, we see the standard increase in neutropenia, the grade 3-4 neutropenia 68% versus 51%, increased respiratory infections, but otherwise infusion reactions, secondary malignancy, discontinuations, not big differences in the two arms.
Your trials have previously informed us a great deal of how to use subcutaneous Daratumumab, and it's a great addition. And another point that we're all aware of is that the optimal treatment of patients progressing on lenalidomide early in their disease course is one that we all face regularly. As a practicing clinician, what are the important or the potential impacts of this particular Apollo trial findings?
So I feel like these are my two children. I've done studies combining Daratumumab with both Pomalidomide and Carfilzomib in the so-called 1001, and those have now gone on to be validated in larger phase 3 studies. And if we kind of think about CD38 with the backbones, we have two with the Carfilzomib Dex, the Carfilzomib Dex with the Cetuximab and the Ikema, or the addition of Daratumumab and Candor. And then now we have Apollo that we just discussed, or the Icaria, which is the addition of Cetuximab to Pom-Dex. And so at a high level, if you zoom out, they look very similar. Hazard ratios are both 0.5 to 0.6 across all four of these studies, suggesting 30 to 40% benefit with the addition of the CD38. And it seems like, okay, well, then it's just dealer's choice. You know, if you're cytopenic, use a PI. If you have cardiac issues, use the POM. But the devil's in the details. And I think we have to think about the comparator arm. Pom-Dex, in some ways, is a historic, almost homeopathic doublet. And of course, it's easy to improve upon that. Now, the KD, they really were using a modern era KD of Endeavor dosing, 56 twice weekly. So when you have that as your comparator arm, it gets even harder to beat that with respect to the hazard ratios. So even though the hazard ratios are the same, what you're achieving is much different with the addition of CD38 to a KD. And so I think that's an important message. Now, of course, there's Canadian perspectives in this that I would love your comments on, but I think the take-home message here, particularly for Len refractory, where we have seen historically in all the randomized studies, even with VD backbone, the Len refractory patients have worse outcomes. And we're seeing very encouraging data from CD38KD on the order of 20 plus months. Whereas here with both of the Pom-Dex backbone, they're definitely better, but we're only seeing 9 to 10 months. So I think that's an important message that if you have a Len refractory patient, consider a CD38KD, barring cardiac issues or older age population. And that's, I think, one of the main important messages. And of course, I would really like to highlight the very exciting Canadian work of taking DPD but adding cyclophosphamide, very encouraging results with a very marked improvement in PFS. So perhaps the question isn't CD38 with either K or P, it's really CD38KD versus CD38 Pom-Dex cyclophosphamide.
That's a wonderful way to summarize things. Thank you. And back to your comment about the Canadian context, we are driven very much by cost considerations, and having more than one option will serve us well and our patients well. So thank you very much for your overview and comment.